and yes, and take us through a short prayer. Then we'll introduce our speaker for today.
Let us pray. Father, we thank you in the name of Jesus Christ for this meeting that we are going to have in learning about stroke. We are grateful for the opportunity, Lord. We pray that the spirit of wisdom, knowledge, understanding, counsel will be upon us. We honor your name in Jesus' name we pray. Amen.
Amen. And now once again, you are all most welcome to this session. This is the second of 3 sessions on sickle cell that we are having concurrently in a series. We had one last week led by Dr. Namazi Ruth, a pediatrician at Makerere University and in Mulago Hospital. And today we are going to have another one, and this time addressing one of the major complications of sickle cell anemia. Just as a recap, sickle cell anemia is now one of the biggest challenges we have in child health in this country. Every year, we have over 20,000 children born with sickle cell anemia. Across the country, 1 in 7 of us is actually carrying the sickle cell gene. So 1 in 7 of us, or 13% of the population, carries the sickle cell gene. Some parts of the country are more affected than the others. Some years ago, the affected children, less than 50% of them made it to 5 years of age. Things have improved with the vaccination, with increasing knowledge and a better care. This number is reducing, but the pain and the living with sickle cell anemia is not for the faint-hearted. And for us as communities, as health workers, taking care of these people is really what we need to do and do well. Although many children are now surviving and growing up into older children, going to primary school, going to secondary school, one of the emerging problems is stroke. And so even those who have gone beyond the early childhood who survive, they reach 7, 8, 9, 10, 12 years, and they get stroke. And today, we have one of our presenters, and our main presenter, who is going to take us through this session. And I'll be introducing him shortly, but before I do that, I would like Benjamin to come and take us through, for those who may be joining for the first time, what is Busoga Health Forum? What is this organization which is bringing us this series of talks? Benjamin, you're welcome.
Thank you so much, Doctor, for this opportunity, for always embracing Busoga Health Forum. For those who are joining us the very first time, you're welcome to this weekly CMEs. They happen every week, every Friday from 8 to 9 p.m. Busoga Health Forum is a non-government organization, and we are having our main offices in Jinja, that's Gabula Road, plot 6, and we are working, we are having interventions in almost all the districts of the region. The organization vision is to see our health and thriving Busoga. That's why we have a lot of projects that we are doing, including these capacity development sessions, the CMEs that we are conducting to support our health workers in the region. And our mission is to convene stakeholders and coordinate partners in efforts to improve the livelihood of the people in Busoga. As a good organization, we have values that we look at, and we really take them as essential. And one of our values is transparency, accountability, teamwork, integrity. And to achieve our vision, we are working through strategies, so our methods of work. We have health workforce capacity building initiatives, just like this one where we are. We have technical working groups. These include the NCDs, technical working groups, the CME technical working groups, among others that we work through to achieve the programs that we are implementing. And the last one is partnership and networking. We value people that are having interventions within the region. So we work together with them to support our people within the region. As a forum, we are a membership organization, and we request that every person who is part of this call, please embrace being a member of this forum by subscribing, because the membership contributes a lot to us implementing these activities. For example, the same that we are attending now, we have to pay Zoom and everything. So this is the membership that we members are paying. The pro bono initiatives we are conducting within the region, one of them being the ENT pro bono activity, where a consultant comes in every once in a month. From the membership we are paying. The NCD screening we are doing around the region, so membership we are paying. So we encourage every person who is part of the CME to become a member of Busoga Health Forum by paying 100,000 shilling a year. That's for individuals. An institution pays for 500,000 shilling a year. And please, you can become a lifetime member by paying 1 million shilling to Busoga Health Forum. Some of our core programs, we have RAMNA, that's reproductive, maternal, newborn, child, and adolescent health. We have interventions in malaria, HIV, and TB, nutrition and early child development. We have interventions in regional planning and data use. So we are an evidence-based organization. So we value data. That's why we have interventions, making sure we have good data. Intervention is non-communicable diseases, and we have interventions in urban health, just like the Urban 3 project that we are implementing in Jinja City and Liganga municipality. Please feel free to contact us on our Twitter, Facebook. You can visit our website. It is very resourceful. All these presentations, like one we are going to have today, can be found on our website. You can go and download them. If you want this video, the recording of this session, please feel free to utilize our YouTube channel. We have these sessions and they are really very good. We thank you so much and welcome you to our session today. Please always come again and attend our CMEs. Thank you so much, Doctor. Over to you.
Thank you, Benjamin. And for those who just joined, I think the last 15 or so people who joined after we started, we say welcome. So today our speaker is Dr. Deogratias Munube. Dr. Deogratias Munube is a consultant pediatrician and a consultant pediatric hemato-oncologist. He trained in Makerere University and obtained a master's in pediatrics and child health from the same institution, and he then took a fellowship in pediatric hematology oncology, and qualified as with a subspecialty training in that area. He then undertook a PhD, and his PhD work has been in the area of stroke in sickle cell anemia. And so it's we couldn't have had the best to give us this talk about management of stroke in sickle cell and anemia. Dr. Munube, the floor is yours.
Good evening, Professor Idro. I hope you can hear me.
Yes, we can hear you very well. And to everyone, in case you have some questions, please hold them or write them in the chat. We'll have them after this session. We shall go through the questions. Dr. Munube.
And can you see my slide?
Very clear.
Yes, very clear.
Okay, so I'll just show my face for those who may not have seen me, and then I'll take off my video because of bandwidth. So good evening once again, and welcome to today's session. So I'll be taking you through the management of stroke in sickle cell disease. And that will be the outline of my talk. We'll go briefly into a few definitions. We'll look at some epidemiology on sickle cell and specifically stroke. We'll talk a bit about the pathophysiology, go into treatment prevention, and then try and discuss a few stroke guidelines which are available and would have a conclusion. So by way of definition, a stroke is a neurological deficit which arises from a cerebrovascular incident. And this must persist beyond 24 hours. And please note the time of 24 hours. Why is this important? Because you may have a similar kind of neurological deficit which can resolve within 24 hours, which is known as a transient ischemic attack. You may also have a similar type of episode which lasts more than 24 hours, which you think may have a vascular component, but you're not able to prove it through imaging or other types of investigations. So what is sickle cell disease? And for all of us to be on the same page, this is a group of inherited disorders which affect the red blood cells. It occurs as a result of a mutation in the beta globulin gene, where there is a change in a protein from glutamine to valine. And this disease is characterized by pain, by low levels of blood, chronic organ damage, and reduced survival. And it's very important to note that sickle cell disease, as Professor Idro mentioned, is a key disease that affects mortality trends in our country and in very many other sub-Saharan African countries. When you look at sickle cell disease in Uganda, and I just want us to possibly just look at a few items that is very important. I'm going to use a pointer. We have been told about the Busoga Forum. And if you look at the East Central, which is the area where Busoga is, you find that the trait percentage is extremely high, close to about 20%. Now, when you come forward to the disease, it's about 1.5%. And this is almost the highest proportion that we see in the whole of the country. If you look at mid-north, which is 19.16, if you look at northeast, which is 15, you still have the Busoga region, which is extremely high. And I think this is very important to have this series of talks so that people increase their awareness within the region and know why it's very important for us to focus most of our interventions in areas where there's high prevalence of the disease and also the trait. So what about our topic of today? Sickle cell disease is a key disease which can lead to stroke. It is noted that close to about 10% of patients who have sickle cell disease will have a stroke by the age of 20. And if you extrapolate this figure, you will find that the older you go, the higher the proportions. If you go to 30 years, 15%. If you go to 45 years, it goes to 24%. But more importantly, this type of sickle cell disease that leads to high prevalence of stroke is the hemoglobin SS, which is also known as sickle cell anemia. So in my talk, I may use these words interchangeably, but whenever I mention sickle cell anemia, you know I'm talking about HBSS. In sub-Saharan Africa, it's very important for us to note that quite a number of people have looked at studies reviewing results from very many countries, and you'll see that this prevalence of stroke can range between 2.9% to 16.9%. Now, the areas where you have very low percentages are areas where they have other variants of sickle cell disease, like hemoglobin SC, hemoglobin S beta, hemoglobin S beta 0. So those other forms of variants when it comes to sickle cell disease end up having lower percentages of stroke, and that's why you see the range is quite large. In Uganda, we now know that the prevalence of stroke is about 7% in our population. So you can see if you compare worldwide and Sub-Saharan Africa, we're somewhere in between, but that's still something that we would like to improve. Specifically, when you look at stroke types are basically two. You can have a stroke that leads to hemorrhage as a result of a rupture of a vessel in the brain, or you can have stroke as a result of occlusion or blockage of the vessels within the brain. Now, arterial blockage versus venous blockage are two main types, but in sickle cell disease, we'll talk more about arterial blockage. And this can be as a result of thrombosis, as we'll see, as a result of embolism, and also as a result of diminished systemic perfusion. And this is where the most important part of this talk will be. So I'm going to take you through the pathophysiology of stroke in sickle cell disease. And more importantly, as we go through this, these are areas where we think interventions can be done. And the stages of sickle cell disease stroke are basically three. And in stage one, you look at some key important aspects, and you can see in this cartoon, it's showing you a red cell which is attaching to the inner lining of your blood vessel. So the red cells are now able to stick, or what we can say, there is this abnormal adherence to our vasculature, which begins the process of the pathophysiology. And as you move on, you find that you get into a crisis, you have hypoxia, you have infections, you have either a lung infection, bacteremia, any form of infection, a meningitis, and you end up with hemolysis. The hemolysis then leads to the breakdown of our red cells and the release of what we call nitric oxide. Now, nitric oxide, as you know, is a potent vasodilator. Now, in this case, there's going to be a rapid breakdown of our red cells, release of nitric oxide, and there will be scavenging or destruction of this nitric oxide. Instead of it being a potent vasodilator, it now becomes absence in the blood, and you end up with vasoconstriction, and that leads to the narrowing that you're seeing. In the past, we thought that sickle cell disease and all the complications was only as a result of our red cell changing from a donut into a sickle cell. Now we know that even the white blood cells, which you can see in this light pink, are also involved in the vasculopathy. They become sticky, just like the red blood cells. They adhere to each other. They adhere to the lining of the vessels, and they end up triggering more and more inflammation. These darker dots that you see in this cartoon are platelets. They are also equally involved in the inflammation. And whenever you look at a complete blood count of a child with sickle cell disease, you always tend to see an increased number of platelets. You tend to see thrombocytosis, 500, 600, 700, and they play a key role also in this pathophysiology. They become sticky, they stick to each other, they bind to the red cells, they bind to the white cells, and this process triggers more and more inflammation. So you can imagine red cells sticking to each other, white cells sticking to each other, platelets sticking to each other. They're all forming a big mesh. And at the same time, there is this increased proliferation of our smooth cells in the inner lining of our blood vessels, an increase in the number of the fibroblasts that you're seeing that I'm pointing out here, all leading to the narrowing of this blood vessel that you're seeing. So this process from stage 1 all the way to stage 8 does not occur at once. It occurs over a period of time. And we'll be discussing this a bit later when we're talking about prevention. So we have the red cells breaking down, sticking to each other, the white cells adhering and narrowing, the platelets doing the same thing, and forming this mesh, which leads to our famous occlusion. And once we have the occlusion here, then it means there is no transmission of blood through the vessel, and we end up with our painful crisis. And in this case, you have what we call almost a complete blockage, where you end up with a stroke. And the commonest type of stroke I mentioned in sickle cell disease is ischemic stroke, and this is how the process comes about. Now, as a result of what I described earlier, there are several things that can happen, and I'll try to highlight a few of those clinical features. The commonest that we tend to see is weakness of one side of the body, or hemiplegia or hemiparesis. However, before we reach that point of hemiparesis, the children or even the adults tend to present with headaches. Some present with abnormal behavior. Some present with seizures. Some can even present with loss of vision. Usually in these events, some of the people may present with a history of an illness or a previous history of a fever. They could have reduced level of consciousness. Some are brought into our service when they're in coma. Some may have previously had a treatment of an acute chest syndrome. So some of these triggers that can lead to sickle cell stroke. They could have had an acute anemia. They could have been a prior history of surgery, and they could have been a previous history of a transient ischemic attack. And I'd mentioned earlier, this is an event where someone may have any of the features I described earlier, a weakness, visual loss that tends to resolve. So the more and more you get a TIA, the higher and higher you get a risk of getting a full-blown stroke. How do we diagnose stroke? I would say we're basically using our simple clinical acumen. We're taking a history in this child. We're trying to document a history of sickle cell disease. And please note that in some cases, there may actually be no previous history of sickle cell disease. This week in our service, we received a 1.5-year-old child who came in unconscious with no previous history of sickle cell disease. But what was outstanding, the child had frontal bossing, had an acute anemia of 2.1, had a total white cell count of 30,000, and the thrombocytosis of 750. When we did a peripheral blood film, it showed clearly on peripheral blood film that this child had sickle cell disease, and the parents had no idea that they were carriers. So even if you receive a child with a weakness, inability to speak, inability to see, and lives in Uganda, based on our prevalence studies and information that Professor Idro stated earlier, you must think about the possibility that this could be a sickle cell disease stroke, because we know now that sickle cell disease is a main contributor of stroke in our population. Looking at some of the acute neurological events, as highlighted earlier, loss of consciousness, seizures, coma, weakness of the side of the body. In some cases, it could be a very acute event. A massive stroke can knock out both the right and the left side of the body. So don't think all the time that it has to be only one side. The patient can present with a quadriplegia, and this is something that can easily occur. Now, what key investigations shall you want to do quickly? You need to know the hemoglobin level. And the easiest way in most of our centers is by doing a complete blood count. Some places may have hemocues where you can determine the hemoglobin level, because your hemoglobin level determines what you do in terms of the management, but it doesn't stop you from intervening. Even a good clinical examination, looking at the mucous membranes, looking at the tongue, looking at the palms, can enable you to determine the pallor state in this child or adult. You want to also screen for underlying triggers. As you look at the chest, it will be important to do a chest X-ray to rule out acute chest syndrome. You'd also want to demonstrate a reduction in the hemoglobin level and acute anemia of an HP of greater than 2 grams per deciliter. And there are many other triggers. Your SpO2 level less than 90%, hypoxia, all of this can trigger the red cells to go into hemolysis and change shape into sickle cells. Brain imaging is something that's very important in our setting. And I'm happy that in very many regional referral centers, now we're able to have CT scans. So we can actually now think of the opportunity of doing this. In the past, if you needed a CT scan, it was limited to very many areas. Some of the standards that are described globally, they would actually recommend an MRI and A as the best investigation. But we know in our setting, this is something that may not be feasible. So a brain CT looking at the evidence of a stroke, and the main reason why we would do a CT at the beginning is actually to determine whether this child has a bleed versus an ischemic event. Because if this child or adult has a bleed, you may need a different type of intervention. You would also need to know the child's HbS and HbF levels, because your interventions that you would do would be guided by the percentage of your HbS. And as I'll talk further on, you would need to remember the number of 30%, because the aim when you give a transfusion is to lower your HbS level to less than 30%. Your HbF levels will be important because some of the interventions would require the introduction of hydroxyurea, where you would monitor with the HbF. And also remember that there are other tests that can be done based on the clinical presentation of this child or adult. So now to the main part of our talk. How do we treat children or adults who may present with stroke and sickle cell disease? We go through the basic practice. We want to make sure that this child or adult has an airway which is patent, that the child is breathing, the circulation is adequate. And important to note is that oxygen delivery in such a child or adult who has a stroke in sickle cell disease is very important, because you want to avert hypoxia. If you have persistent hypoxia, you have a barrage of red cells changing shape from a donut shape to a sickle cell shape and lead to what I described earlier. So in most cases, this child who has a sickle cell anemia with a stroke will be given oxygen as a result of reducing the risk of hypoxia. Blood transfusion is a key intervention that is required. It can be simple, that means top up, or it can be an exchange transfusion. And for those who may have been here last week, Dr. Namazi explained a lot about the exchange transfusion. Secondly, we would want to look at any underlying triggers. If there are some triggers that could have pushed this child into a stroke, you would want to treat them. Sometimes it could just be the anemia, it could be a chest infection, it could be a bloodstream infection. You'd want to cover based on any of those factors. Most importantly, in this child, you would like to initiate on hydroxyurea, and we'll talk a bit more about this in a subsequent slide. If this child was on hydroxyurea and ended up with a stroke, then there is a need to review the current dose and escalate the dose of hydroxyurea to what we call the maximum tolerated dose. And this would enable you to reduce the risk of secondary stroke. In children and adults with sickle cell disease, when you get one stroke, the risk of getting a second and third is as high as 300 times. So you don't want to put this risk into such a child. You want to ensure that you reduce on that risk. After the event of a stroke, sometimes if you're not able to initiate immediately hydroxyurea, you might need to plan for chronic transfusions. And the aim of the chronic transfusion is to dilute the HbS level to less than 30% so that you can reduce the risk of sickling and the risk of all the inflammations that can occur as a result of the breakdown of the red blood cells. Please always remember, after a stroke, this child or adult needs rehabilitation, physiotherapy to enable them to use their limbs, occupational therapy to enable them to go back to school and work, speech and language therapy, because they may need these specialized services. When people get strokes, especially in the middle cerebral artery, around the area of the Broca's, they tend to get expressive aphasia, and your speech and language therapist will enable us to improve their outcomes. Now, specifically to primary prevention, when you look at all the studies that have been done when it comes to sickle cell disease and stroke, it's very important for you to be able to identify those children who are at risk of stroke. People with sickle cell disease are at a high risk of stroke between the ages of 2 to 10, and sometimes it can go up to about 18. Earlier, I mentioned that you would end up with a stroke by the age of 20 years. If you look at the natural history of sickle cell disease, about 10% of the children will get a stroke. The transcranial Doppler screening enables you to determine how fast the large vessels are pushing blood through, the speed of the blood going through the large vessels. And if the speed is very high, it means that one, this child could be at a risk of stroke, and this is a child that you would need to initiate some intervention. And the two main interventions are chronic blood transfusion, which can be monthly, depending on the availability of blood, can be hydroxyurea. If it's not been initiated, you initiate it and increase the dose. And more importantly, if you do a transcranial Doppler screening and this child is at risk of a stroke, you would initiate these components, such as blood transfusion and hydroxyurea, and then you'll be able to review the child after about 3 months of age from the time that you have seen them. And then thereafter, you repeat your transcranial Doppler screening. It's also important to note that transcranial Doppler screening is not readily available in Uganda. We have a few centers that can provide it. And I'm very well aware within the Busoga region, there's a health center, I think in Wikwe, if I'm right, that does have transcranial Doppler screening, and it's being offered through a program. Outside of that, whoever needs a transcranial Doppler screening would either have it done in Kampala or in Mbale, where there are some studies which are ongoing. So primary prevention is key. We would like to prevent the occurrence of stroke in these children. However, since we are managing stroke, what happens when you get a stroke? We want to prevent secondary stroke occurrences. And still, as I mentioned earlier, you would need to initiate these children or adults on chronic blood transfusion. Please note that if you have a stroke, there is no role of a transcranial Doppler in this case. You have already had an occlusion, and you will not be able to determine how fast or how slow the blood vessels are pushing the blood through. As you initiate on your chronic blood transfusions, you need to worry about the risk of getting iron overload. And as been explained earlier, you find that this is something that we don't see so often because very many of our children and adults have low levels of iron. In the demographic surveys, you find that Uganda is within the high IDA or iron deficiency anemia countries, where about 60 to 70% of people in Uganda would have iron deficiency. And this also includes our children and adults with sickle cell disease. We need to monitor the HbF levels, because as we start on hydroxyurea, we will increase the production of the fetal hemoglobin. As we give blood transfusion, we will reduce the percentage of hemoglobin S. So these are some key factors that you need to look at as you are managing the child. And hydroxyurea is given for life, and it's very important for us to look at the monitoring to ensure that the clinical response is appropriate so that we reduce the risk of secondary stroke. Now, going specific to some of the guidelines, as I mentioned, if you look at the American Society of Hematology or ASH guidelines for the prevention and diagnosis and treatment of stroke or cardiovascular disease and sickle cell disease, they highlight three main things. In these guidelines, they were able to review 19 different types of interventions which could be used to prevent stroke, and they found three things. One, the use of transcranial Doppler screening. Two, the use of hydroxyurea. And then three, having a surveillance system in children and adults with sickle cell disease to observe some key things, to look at their development, if there are any delays, to look at their cognitive characteristics, to see if there's any impairment, and also to look out for any neurodevelopment disorders. So as you want to prevent stroke, you also think about all these things that are there. You may find a child who should be in senior 6 is in P7 as a result of cognitive impairment. You may find a child who is so small compared to his age as a result of developmental delays in terms of growth. If you go outside of the ASH guidelines, what do we have within Africa? And I'm happy to share with you the Sickle Cell Pan-African Consortium Standards of Care Guidelines for Stroke, and they too clearly identified the similar things that the ASH guidelines said. One, you should be able to screen our children early so that you identify those who are at risk of stroke, you initiate those who are at risk of stroke with hydroxyurea, and start all children from 9 months of age with hydroxyurea. Two, you want to manage their acute stroke. You need an immediate blood transfusion, whether simple, whether exchange. But in most times, we tend to have a simple blood transfusion, which is what we do with most of our children and adults. When we go specifically to our Uganda Clinical Guidelines of 2022, I'm happy to say that stroke has been included in the guidelines. However, it does indicate that care of a child who has sickle cell disease stroke should be at least the level of a referral hospital. And in the guidelines, it says a regional referral hospital. Provision of oxygen, as I mentioned earlier, to avoid hypoxia, blood transfusion, fluid maintenance, and for those who need higher care, you would refer. And in this, at that time when these guidelines were made, the reason for referral at that time tended to be for imaging. But now with the availability of CT scans, you may only refer for other advanced things, but not necessarily for imaging. Now, we also have our national guidelines for the management and prevention of sickle cell disease, and it actually clearly highlights two things. One, how do you manage stroke? You look at the general principles of care. You have the guidance of your senior who is available, either a pediatrician or a physician, or you can consult. But most importantly, the need of a blood transfusion. For prevention, it clearly states, initiate hydroxyurea, offer transcranial Doppler screening, and offer chronic blood transfusion. Now, although I mentioned earlier that transcranial Doppler screening is not available, but we at least know that we are going to aim and push for it once it is within our guideline. In conclusion, I'm happy to remind us all that one, sickle cell disease is a common cause of stroke in children. Acute management of stroke requires immediate blood transfusion. Chronic management requires monthly blood transfusion. Initiation of hydroxyurea can help in preventing both primary and secondary stroke. and transcranial Doppler screening is a key modality to reduce the risk of stroke in our population of sickle cell disease. I'd like to thank you all for listening and acknowledge the Busoga Health Forum and all our partners. And I'm ready to take some questions and comments from my presentation. Over to you, Professor Idro.
Dr. Munube, for an excellent presentation. Join me to congratulate and thank Dr. Munube for a well-designed talk and delivered talk. And indeed, there has been many comments of thanks for a well-delivered talk. We are now going to go to questions, and you can raise your hands, but as you do so, there have been several questions on questions chat, and if I can pick them through, a number of them are around transfusion, but the others are around stroke. So one, what are the indications for the transfusion? I know you have said this, some of this, but you can repeat them for clarity. How much blood should you give? And as you give this blood, are you not worried about iron overload? What is the risk of iron overload? And when these strokes develop, can you use thrombolytics? Can you use antiplatelets? Do they have a role? What is the prognosis of stroke? And I think that will be the first set of questions. Then I'll come back to the ones which are mechanics of transfusion. What are the indications? How much blood do you give? Is there a risk of iron overload? Antiplatelets, thrombolytics.
Thank you, Richard. I will go straight to the indication for transfusion. So it's important for us to note that in our setting, more than 90% of our children tend to present with low hemoglobin levels. And when we are transfusing, the aim of the transfusion is really for dilution. We want to reduce the percentage of HBS. We want to reduce the risk of other red cells going into a crisis, from getting from a donut shape to a sickle shape, and leads to rupture and leads to release of nitric oxide, leads to inflammatory processes and occlusions. So that is the main reason why we transfuse. We give either packed cells or we give whole blood. And this is something that always comes up. What is best? We know from studies, and recently there is a transfusion study called TRACT, which has been done, which has shown either whole blood or red blood cell would be appropriate. So we don't have to struggle to look for either. Of course, the volumes now vary. Packed red blood cells, 10 mils per kg, whole blood, 20 mils per kg. And you give your transfusion, and then you review the hemoglobin change. Although we know when you give a blood transfusion, you have up to a 2-gram rise, but sometimes you want to be able to document this rise. Iron overload, I mentioned it earlier. 70% of Ugandans, based on our Uganda Demographic Health Survey, have iron deficiency. So right now, I won't want to say we are blessed that we have low iron in the country, but it has enabled us to see less and less cases of iron overload. Even in those patients who were giving chronic transfusions, we tend to see maybe 1 in 100. And amongst those are the patients who actually have signs and symptoms. Thrombolytics, very, very important question. Why don't we use TPA when these children or adults present with stroke? I spent time to explain to you the pathophysiology around it. Thrombolytics tend to look at plaques. And if you look at the process of stopping bleeding or reversing stroke, it is not the same when it comes to sickle cell disease. I demonstrated to you that you have white cells involved, you have red cells involved, you have platelets involved. So TPA as a intervention would not show any change in the outcomes. Even aspirin, the same process, because the pathophysiology is a combination of cells. Some of these thrombolytics are of no use to us. Prognosis of stroke. In the early days, prognosis was very poor. I would tell you close to about 50% of the children would die. But over the last 5 years, that mortality has significantly reduced to less than 10%. Children who have IFR stroke, with a good intervention, you reduce the risk of subsequent strokes, but they become debilitated. So it's something that you need to have what we call a group discussion with yourself and the parents to explain why you need to prevent subsequent strokes. Over to you, Richard.
Okay, thank you. Just a few additional questions before I come online, and they're around fluids. So if it is due to occlusion, can giving the patient fluid help in diluting this? What about in a person in whom you suspect that there is concurrent sepsis and stroke? How do you manage it? And then won't this blood cause problems if the cause was hemorrhagic? These are the ones which have matched, and then we can go to the ones which are online. And that you have not answered the question about at what hemoglobin level you should transfuse, and what about congestive, an interesting one, congestive cardiac failure in sickle cell anemia.
Okay, so thank you. So I think it's very interesting that we are bringing up all other complications that can occur. Now, when you look at sepsis, as I mentioned earlier, that when you're taking a history or when you're examining a child, you may find that the trigger may be infection. And that infection needs to be resolved. So your choice of IV antibiotics would depend on the severity of the illness, whether you start with first line, whether you start with second line. So all your decisions around that will depend on your patient. And sometimes I don't want to limit and say if someone comes with a fever and sickle cell, you give ampicillin. Or if a patient comes with fever and a chest infection, you give ceftriaxone. So your decision on what you give will depend on your assessment of what type of sepsis. Fluids and occlusion, very important. If it was only as a result of occlusion, then why can't fluids reverse the stroke? Now, fluids can help with reversing the sickling. Okay, fluids can help in reversing the sickling. Fluids cannot help in reducing the percentage of your HbS. Fluids cannot help in increasing the HbF percentage. So it is one of the what we call supportive managements, but it cannot be your definitive. And that's why I highlighted the reviews that were done to see what is very important. Hemorrhagic stroke is managed neurosurgically. Hemorrhagic stroke is managed neurosurgically. If you don't intervene and get the blood out, that patient will die. So it's very important that we do not use similar protocols. However, as I mentioned, ischemic stroke in sickle cell disease, over 95% of the children will have an ischemic stroke. Less than 5% will have hemorrhage. Congestive cardiac failure, sickle cell anemia, and stroke. This congestive cardiac failure, or the heart failure, can be one of your triggers. We don't see it so often because it is one of the things we look out for, but we don't see it so much. We tend to see more of acute chest syndrome. So more lung infections than heart diseases can actually trigger off you going into a stroke. Someone mentioned, and I think I saw the guidelines say a regional referral. Yes, like I mentioned, the guidelines state that because the availability of specific drugs and interventions will be at that level. In most cases, a simple blood transfusion may be your key factor. And I've actually ever seen this in a child who presented to a health center. I got a call, they told me about this. I said, give a blood transfusion. This child came in with visual loss. And because of the intervention of the medical officer at that time, the child recovered sight. So your first key intervention will be a blood transfusion. Why is it so? Most of our children are anemic. The average hemoglobin level of a child with sickle cell disease is between 6.5 to 7.5. So most times they will always need a blood top-up. Richard, there are some hands up. I don't know if we're going to take them or we continue with the slides. I mean, with the chats.
We now take the hands. There are only two. First Eva, and then two Silas. And when you finish them, there is just one comment online from Paul Atoki from Hoima, that also regionally, from your presentation, Bunyoro area seems to be having a high burden, but they do not have a functional clinic. Is there some kind of support for which can be generated for Hoima Regional Referral Hospital? And then we shall end with these ones. Eva, then Silas.
The first can that is
Eva, your link is quite poor. We can hardly hear you. Please type it.
She mentioned something about the TCDs, but she can type it. I had something in passing.
Okay, Silas.
Yeah, thank you very much, Dr. Munube. Sorry to drag you back on the pathophysiology. You talked of the proliferation of the perivascular tissues. So I was thinking, if one of the causes of the proliferation is cerebral edema, we would think of maybe using also hypertonic saline. So maybe would give us maybe the causes of that proliferation. Maybe it is inflammation, would use maybe anti-inflammatories. Thank you.
Yes, very important. And as I mentioned, as we look through the pathophysiology, each of the processes I described, you should be able to intervene. However, the proliferation of the smooth muscles are really as a result of the inflammatory markers. Now, how do you stop these inflammatory markers from increasing? It is a process that I described. When your red blood cells hemolyze, they release nitric oxide. Now, nitric oxide is scavenged by endothelium-1. Now, endothelium-1 is the key inflammatory marker that leads to the proliferation of your smooth muscles and your fibroblasts. So it is released to mop up the nitric oxide. And as a result of mopping up the nitric oxide, you cause vasoconstriction. Nitric oxide is a potent vasodilator. So if we are able to intervene like how you've pointed it out, and I think that's a very brilliant thing that some of you could take it up and see how we can stop the scavenging of the nitric oxide and keep it within the blood vessels so that the blood vessels are able to enlarge or vasodilate instead of vasoconstricting. And that would be a new intervention, and maybe we'll call it the Silas intervention. Very, very important. That was a brilliant question. Richard, over to you.
Thank you very much. Once again, I'd like us to thank Dr. Munube for really a well-delivered presentation, for developing his presentation and delivering it and sharing it with us today. And unfortunately, time is very short on our side. And I would like to bring this session, the discussion on to an end. And I would like to hand back to the Secretariat for Busoga Health Forum to take us through the next few minutes and then close the session. Benjamin.
All right, thank you so much, Doctor. It's been a wonderful presentation. Thank you, participants. The series of sickle cell continue. We shall have this topic continuing of sickle cell even next Friday. I request we embrace membership and subscribe to Busoga Health Forum so that we support these activities to continue. Right now, I don't want to go into much. I want to call on Dr. Kabweru Wilberforce Musoga to give us closing remarks on this session, and then he will award certificates to participants. Thank you so much, Dr. Kabweru. You're welcome.
Thank you very much, Benjamin, and I would like to take this opportunity to thank our mentor, Professor Idro, for moderating this session, and eminently to thank Dr. Deogratias Munube, who is my colleague at Mulago, for ably presenting and giving us a lot of information and guiding us in terms of management. We know that actually Busoga region has a very high prevalence for sickle cell, and I think this speaks to us and guides every person, whether you're a health worker or not, to see that in case your child has such a condition, you run very fast to the nearest health facility. Without more ado, I would like to thank Dr. Munube for doing this subject justice and for enlightening us, and thank you for honoring our invitation, and we always welcome you every time you want to give us something. So on behalf of Busoga Health Forum, I present this certificate of appreciation to you, Dr. Deogratias Munube, and we thank you for your wonderful presentation. May God bless you. And on the same note, I want to thank Professor Idro Richard, our mentor in pediatrics and a number of things, for never leaving us alone and always running to our help, and for bringing us such a very good presenter, and for the guidance, and even for him also coming around Busoga Health Forum to present, and then a woman, the rest. Surely we are always indebted, Professor Idro, and you're always most welcome to Busoga Health Forum. So I present to you this certificate of appreciation on behalf of Busoga Health Forum. May God bless you, and for God and my country. Thank you very much, and a good evening.
Thank you. Good evening.
evening to you. So over to you, Benja, please.